Hi, everyone. Welcome to Massive Bio's Lymphoma webinar. My name is Fiona Evans. I am the Director of Patient Relations here at Massive Bio. I'm happy to be here, and I'm joined today by Dr. Alba Redondo. Welcome. Thank you so much for joining us today.
Thank you. Well, my name is, like you said, Alba Redondo. I'm actually a hematologist, and I'm working like a head of the department here in Extremadura, Spain. So it's a pleasure for me, your invitation, and I'm ready when you want.
Great. Thank you so much. So we will jump right in. We're all eager to learn about lymphoma today. So what are the standard treatment options available for different types of lymphoma?
Okay, let's begin by describing the treatment option for the two existing types of lymphoma. Therapeutic options available for classical lymphoma include chemotherapy with various agents such as ABVD, adriamycin, bleomycin, vinblastine, and dacarbazine. This is one of the most widely used due to its effectiveness and low toxicity profile in patients with advanced disease. Other more intensive combinations like Stanford B or BCOL yield similar results with increased toxicity. Brentuximab vedotin in the first line improved overall survival and is approved now in Europe.
That's fantastic. And can you elaborate on the role of radiation therapy in lymphoma treatment? And when is that typically recommended?
Of course, treatment may also involve radiation therapy with dose ranging from 20 to 40 grams or a combination. In the past, most chemotherapy with methotrexate, nitrogen mustard, procarbazine, and prednisone caused significant cardiac toxicity, and radiation therapy led to excess pulmonary toxicity due to high dose affecting a wide area. Currently, dose and file size for radiation therapy have been significantly reduced, aiming to minimize side effects. Treatment choice should be individualized, taking into account each patient risk determined by prognostic factors. Nodular lymphocyte predominant Hodgkin lymphoma is a rare subtype, 5%. The same treatment strategy as classical Hodgkin lymphoma is applied, but in localized stages without adverse prognostic factors, radiation therapy alone is used. In other stages, ABVD chemotherapy, similar to classical Hodgkin lymphoma, and the monoclonal antibody anti-CD20 rituximab are employed due to CD20 expression by tumor cells. For the treatment of non-Hodgkin lymphoma, factors such as histology, lymphoma extent, prognostic factors, general health, and age of the patient must be considered to distinguish between indolent or aggressive lymphoma. Generally, chemoimmunotherapy using various combinations of cytostatic agents and monoclonal antibody is used. Future development aims to incorporate target agents that increase efficacy while reducing toxicity. Local treatment with radiation therapy is only indicated for very localized indolent lymphoma at dose of 35 or 45 grays, or as an adjuvant therapy after chemotherapy in patients with bulky masses, plus than 10 centimeters.
Got it. And how does the treatment approach vary between indolent and aggressive forms of lymphoma?
The most common example of indolent lymphoma is follicular lymphoma, where localized stages with minimal tumor mass are treated with radiation therapy. Systemic treatment is indicated for advanced stages with commonly used regimens combining rituximab and the CD20 monoclonal antibody with cyclophosphamide, vincristine, and prednisone, or cyclophosphamide, adriamycin, vincristine, and prednisone, CHOP, or bendamustine, depending on individual patient characteristics and prognosis. In gastric lymphoma cases localized to the mucosa, antibiotics are used to eradicate Helicobacter pylori, often achieving complete remission. Cases with recurrence or deepened penetration of the gastric wall are treated with local radiation therapy or anti-CD20. In splenic marginal zone lymphoma, splenectomy achieved prolonged remission, and rituximab has also shown good responses. Zanubrutinib approved in refractory relapse. The primary representative of indolent T-cell lymphoma is mycosis fungoid. Topical treatment, corticosteroid, nitrogen mustard, carnostan, Soralen plus ultraviolet A, phototherapy, or superficial radiation therapy are used for localized lymph lesions. Systemic treatment with interferon alpha, retinoid, or interleukin 2 inhibitor with or without phototherapy or radiation therapy are recommended for dissemination plaque lesions or tumor lesions. Brentuximab vedotin is CD30 positive or mogamulizumab approved. If this fails, liposomal anthracyclines, purine analogs, gemcitabine, or CHOP may be used. Treatment measures for general erythroderma or leukemizations are palliative. In TNK lymphoma, mostly aggressive, CHOP treatment is often insufficient. Etoposide is added to the CHOP regimen. An autologous transplant is indicated, along with the introduction of new agents such as gemcitabine, L-asparaginase, first line of non-SALT NK lymphoma, alemtuzumab, or another experimental drugs, demonstrating greater anti-tumor efficacy than traditional agents. The greatest advance has been the introduction of rituximab vedotin combined with CHP for ALK positive and ALK negative anaplastic patients.
Can you explain the potential side effects of current lymphoma treatments and how are those managed?
Okay, we need to make a clear distinction. Patients with Hodgkin lymphoma primarily receive treatment with chemoradiotherapy using ABVD, BCOP, Stanford B, or radiation therapy. ABVD is the most common, causing mainly hematological toxicity like neutropenia, occasionally leading to treatment delays or need for colony-stimulating factors to continue chemotherapy. Patients often report being able to carry on with daily activities without significant disruptions, except for occasional nausea, vomiting, or loss of appetite, especially on the day of chemotherapy application or even 24 or 48 hours following. With the more intense chemotherapy regimens like BCOP and Stanford B, they are grade 3 to 4 toxicity that may require treatment interruption or even a change. The most frequent are hematological toxicity, grade 3 to 4, or infectious toxicity, grade 3 to 4. Patients undergoing radiation therapy face a different set of issues. For example, those receiving cervical irradiation need monitoring of thyroid function with thyroid-stimulating hormone and T4, and it may sometimes lead to temporary sterility, particularly with alkylating agent causing reproductive functions, alterations, and anthracycline-inducing cardiac toxicity. Long-term survivors may as time develop secondary neoplasms such as colorectal, lung, or breast cancer. Generally, the chemotherapy received by Hodgkin lymphoma patients do not negatively impact their quality of life, since it allows them to continue performing their usual functions and activities with some specific limitation, as I mentioned earlier.
Got it. And I know you did touch on this in your previous answer there, but can you explain the role of chemotherapy in lymphoma treatments and its impact on patients?
Well, on the other hand, non-Hodgkin lymphoma patients mainly receive the monoclonal antibody, anti-CD20 rituximab, specifically targeted for this type of lymphoma. Patients tolerate chemotherapy well, occasionally experiencing hematological toxicity like neutropenia or thrombocytopenia, requiring growth factor or platelet transfusion, leading to chemotherapy site delays. They also report nausea, vomiting, and hair loss, but overall the cycles are well tolerated, administered every 21 days and complete within 6 months. Patients don't perceive it as a serious illness and are not significantly limited in the daily quality of life. So it doesn't interfere much with their day-to-day activities. However, when they need more intense chemotherapy like rituximab, etoposide, fludarabine, cisplatin, prednisone, for example, requiring hospitalization, patients may experience increased hematological and digestive toxicity with more adverse effects. In these cases, when the chemotherapy is more intense and hospitalization is necessary, patients perceive the process as more severe, feeling worse, and it interferes with the daily life and that of their main careers.
Okay, so mostly patients have limited impacts unless they have more aggressive chemotherapy, and then
Exactly.
The side effects can be more impactful. So, okay, great. What clinical trials are currently underway for lymphoma, and how can patients access them?
Currently there are a lot of ongoing clinical trials with open recruitment for various types of lymphoma. Now I'm going to explain the clinical trials for large B-cell lymphoma in the first line of treatment. The ERCHOP CELMOD trial is a phase 1b open-label, global, multi-center, dose determination, randomized, dose expansion study aimed at determining the maximum tolerated dose, assessing the safety and tolerability, pharmacokinetics, and preliminary efficacy of iberdomide or CC99282. This study combined this agent with ERCHOP21 for subjects with previously untreated, poor risk EP3 to 5, and aggressive B-cell lymphoma. Another trial, ERCHOP glofitamab, is a phase 2 study evaluating the safety and efficacy of glofitamab in combination with rituximab, plus cyclophosphamide, doxorubicin, vincristine, and prednisone in circulating tumor DNA high-risk patients with untreated diffuse large B-cell lymphoma. The epcoritamab combined trial is a phase 1b/2 open-label study assessing the safety and tolerability of epcoritamab. Is an anti-CD3/CD20 bispecific antibody administered subcutaneously in combination with antineoplastic agents in subjects with non-Hodgkin lymphoma. Now, for the indolent B-cell lymphoma, follicular marginal in the first line of treatment, we have EONH-LON20 is a global multicenter phase 1-2 trial of EO2463, a novel microbial-derived peptide therapeutic vaccine, either as monotherapy or in combination with lenalidomide and rituximab for the treatment of patients with indolent non-Hodgkin lymphoma. EO2463 is composed of 4 microbial-derived peptides mimicking cytotoxic T cells, CD8 positive T cell, HLA-A2 restrict epitopes from B-cell antigens and a helper peptide derived for human telomerase reverse transcriptase catalytic subunits administered subcutaneously. Now, for T-cell lymphoma, in the first line of treatment, brentuximab vedotin is part of a dual cohort open-label phase 2 study evaluation the efficacy and safety of brentuximab vedotin and CHP in the frontline treatment of subjects with peripheral T-cell lymphoma with less than 10% CD30 expression. For other type of lymphoma, we have Olympia-1 is an open-label study assessing the anti-tumor activity and safety of odronextamab, an anti-CD20, anti-CD3 bispecific antibody in patients with relapsed or refractory B-cell non-Hodgkin lymphoma. EPCOR is a phase 1b/2 open-label trial to assess the safety and preliminary efficacy of epcoritamab in combination with other agents in subjects with B-cell non-Hodgkin lymphoma. Sonrotoclax is an inhibitor of BCL2. It's a phase 1b open-label dose escalation, an expansion study of BCL2 inhibitor in patients with major B-cell malignancies. Netrabutinib, a non-covalent BTK inhibitor, is part of the phase 2 study to evaluate the efficacy and safety of MK-1026 in participants with hematologic malignancy. Loncastuximab tesirine combined is a phase 1b open-label study to evaluate the safety and anti-cancer activity of this drug with other anti-cancer agents in patients with relapsed or refractory B-cell non-Hodgkin lymphoma. Filobertamab vedotin monotherapy or combined is a multicenter open-label phase 2 study to evaluate the safety and efficacy of MK-2140 as a monotherapy or in a combination in patients with aggressive or indolent B-cell lymphoma. And the last inhibitor of BCL2-XL AZD0466 is part of a modular phase 1-2 open-label dose escalation and expansion multicenter study to assess the safety, tolerability, pharmacokinetics, and preliminary efficacy of these drugs as monotherapy or in a combination with anti-cancer agents in patients with advanced non-Hodgkin lymphoma.
So there are lots of great studies out there, and patients should talk to their doctors, their team about trials. I'm sure many doctors are already bringing that topic up to their patients, but patients can also ask about available clinical trials. That's great news that there are so many available. And what are the emerging therapies and advancements in immunotherapy for lymphoma?
Well, non-Hodgkin lymphoma is a malignant tumor with an incidence of 20 cases per 100,000 inhabitants, with the most common being diffuse large B-cell lymphoma, followed by follicular lymphoma. Despite being considered a curable malignancy with a 60% 5-year survival rate, approximately 20% to 30% experience relapse or refractory to the first-line therapy. The standard of care for relapsed refractory patients is salvage chemotherapy, followed by autologous stem cell transplantation. However, 40 to 50% of patients are ineligible for auto-ESCT due to chemo-refractoriness or underlying comorbidities. Among those who undergo transplantation, 50 to 60% relapse, leaving limited options, including allogeneic stem cell transplantation, feasible only for a minority with less than stellar outcomes. There is no standard treatment for diffuse large B-cell lymphoma refractory relapse after 2 or more lines of treatment, achieving a 7% complete remission rate with a median overall survival of only 6 months.
And are there any promising developments in the use of CAR T cell therapy for lymphoma? And what challenges still need to be addressed?
Well, there are few approved CAR T cell therapies in lymphoma. The first one, Yescarta, AC treatment targeting CD19 for patients with certain type of relapsed refractory large B-cell lymphoma after at least 2 other kinds of treatment, DLBCL not otherwise specified, primary mediastinal large B-cell lymphoma, high-grade B-cell lymphoma, DLBCL arising from follicular lymphoma. For the treatment of adult patients with relapsed or refractory follicular lymphoma after 2 or more lines of systemic therapy. The second one, Tecartus Rexu, is a treatment targeting CD19 for patients with relapsed or refractory mantle cell lymphoma. The third, CAR-T Brenjasi Liso, treatment targeting CD19 for patients with certain types of large B-cell lymphoma, including diffuse large B-cell lymphoma, not otherwise specified, high-grade B-cell lymphoma, primary mediastinal large B-cell lymphoma, and follicular lymphoma, grade 2, who had not responded to or who have relapsed after at least 2 other types of systemic treatment. The fourth one, Primrehab TISA, a treatment targeting CD19 for patients with certain type of relapsed refractory large B-cell lymphoma after 2 or more lines of systemic therapy. DLBCL not otherwise specified, high-grade B-cell lymphoma, DLBCL arising from follicular lymphoma. And currently, an ongoing FLUMA 23 clinical trial is an adaptive phase 3 randomized, open-label, multi-center study to compare the efficacy and safety of AXID versus standard of care therapy or first-line therapy in subjects with high-risk large B-cell lymphoma. Hence, there is an exploration into CAR-T therapy in early disease stages to optimize responses. The access of CAR-T cell therapy depends heavily on the medical community's abilities to manage its toxicities. We need to develop new protocols and design drugs to enhance immune response modulation. A deeper understanding of the pathophysiological basis of this complication is crucial for a rational approach. While there is some global consensus on cytokine release syndrome, immune effector cell-associated neurotoxicity syndrome, management protocols, ongoing clinical trials may continuously revise current guidelines. Questions regarding the optimal drug type, dose, timing, and their potential impact on CAR-T therapy efficacy are far from clearly defined.
Understood. What supportive care measures are in place to help patients manage the physical and emotional challenges of lymphoma treatment?
Well, patient care and their primary caregiver are crucial because sometimes disease take a toll not only on the patient, but also on the person constantly by their side. Well, when I first met a patient, my initial step is to communicate the diagnosis, discuss prognostic possibilities, and outline potential side effects. I always focus on the support the patient receives from their family, inquire about their reproductive desires, and based on all these aspects, I decide on the best course of action tailored to the individual. If I sense that the mental stability or distress caused by the new diagnosis could be detrimental, I offer psychological support. I also consistently recommend health habits, both in terms of nutrition and physical exercise, within the limits of what is feasible and appropriate for the patient's condition. Throughout the process, we aim to accompany the patient and make the illness more manageable, emphasizing with patients and understanding their circumstances is crucial to adapting and doing what's best for all of them.
Yes, definitely. How does the healthcare team collaborate to create individualized treatment plans for lymphoma patients?
Well, the most important thing is to understand the patient care involves a multidisciplinary team, and our colleagues are there to assist and guide us through the possible and numerous complications that may arise during the course of the disease. It's crucial to know the hospital where we work actually. Now I'm working in Korea, a regional hospital, so I'm as a hematologist in a regional hospital. I need to be aware of the treatment I can offer and those I cannot. If a patient enters a cycle of relapse and salvage treatment, I must know when and where I have to refer them and what clinical trials are available at that time. Because we must be humble and recognize when we can no longer continue. There are other hospitals and colleges with more resources and capabilities, and we also need to stay updated, studying every detail and knowing each moment what the real options are for our real patient in this moment. And for me, I want to thank you, Massive Bio Project, because it's providing support in identify suitable trial for each patient with the use of artificial intelligence, which can be useful as it may simplify the identification of the available trial and save time. And it's real and good for everyone.
Well, thank you so much for that. As you mentioned, we do use artificial intelligence to sort through all of the clinical trials that are available today. As you know, it's a challenge to
Every patient, they are
right.
different and the disease are different. So
Exactly. So we are happy to help any patients and physicians to identify useful trials for them.
okay.
And that wraps up our
We are
talk
really
today.
grateful for your help.
Oh, we are so thankful for everything that you do for patients, and thank you for taking your time today. We appreciate it, and I hope you have a great rest of the day.
Okay, thank you. The same to you.
Thank you so much.